Well, welcome everyone to this. We're launching a report, the Psychosocial Support report with Community Mental Health Australia. And so I'm very glad to have Cathy O'Toole and Kerry Hawkins from Community Mental Health Australia with us today to launch this very important report capturing the economic value of psychosocial support. I'd like to begin by acknowledging that at UWA, we're on Whadjuk Noongar land, and I'm actually in Canberra at the Community Mental Health building organisation on Ngunnawal land here in Canberra. So I'd like to just first of all ask Cathy, the President of Community Mental Health Australia, to start us off. Thank you, Cathy.
Thank you, Paul. As we celebrate 50 years of NAIDOC, it gives me great pleasure to acknowledge that I live on the unceded lands of the Wulgurukapa and neighbouring Bindal people land. I pay my respects to their elders, past, present and emerging. I also pay respects to any Aboriginal and Torres Strait Islander people who may be with us here today in the webinar. CMHA recognises people with lived experience as the right holders and knowledge holders. Our purpose is to be ambitious for change, where human rights are at the heart of the mental health system. Interactions driven by community managed mental health sector organisations in partnership with lived experience. CMHA is driven by a vision of transformation, and that is why today it is so exciting for us to be part of this amazing innovative study where human rights will be at the heart of mental health systems and people with lived experience are co-leading change. Our work grounded in values that shape every aspect of how we engage, advocate and collaborate. This is why we commissioned this amazing work. This is an economic report about people. We recognise that people's lives cannot be reduced to numbers alone. However, economic analysis strengthens our collective voice and helps guide the investment, policy and system design. I would now like to hand over to Kerry Hawkins, our CEO, to comment further.
Thanks very much, Cathy and Paul. And acknowledging I'm on unceded Whadjuk Noongar here in Boorloo. And just briefly want to spend a tiny amount of time. Today we're very, very keen to hear from Paul and his team about the economic case for investing in psychosocial support, but we think it's also really important to give some context to why this is such an important event. And to give some context to the work that's been surrounding this work, and so Community Mental Health Australia has been very privileged to work in close partnership with the 3 Australian lived experience peak bodies, the National Mental Health Consumer Alliance, the Indigenous Australian Lived Experience Centre and Mental Health Carers Australia, together with Gaia Dewey, in everything that we're doing. Because, as Cathy said, we're a very, very values-based and driven organisation where human rights is at the forefront of everything we do. And we were very, very fortunate in March to launch the preliminary discussion paper for this study in collaboration with our alliance partners. And we'll continue this work. Our next step with our alliance partners is to work with Paul on a workshop in a couple of weeks' time where we co-create the next few steps. So it's just important to note that this report isn't a standalone launch event today. It is part of significant and deep work that we're doing with our partners and we will continue to do with our partners. But to locate this report also within a policy framework where the reason we are quite excited about this is not because the value of psychosocial supports is a new concept, certainly for people with lived experience and their allies. There is no doubt that internationally and over the decades, there has been tremendous demand for these kinds of supports. And certainly if you go onto the websites of any of our partner organisations, you will see that they have all put out position statements over many years, in many cases, as part of their movements, asking for investment in recovery-oriented services or person-centred services or rights-based services. And most recently, of course, now we're using the language of psychosocial supports. And there will be position statements on all of our organisational partners' websites calling for exactly these things. But what is new for this report, and we think it fills an important gap, is that obviously it's an innovation and a disruption to our highly clinicalised mental health system at the moment, but also a system that makes it very difficult to introduce change because we have no measurement frameworks for understanding how our money is being spent. And so most of our investment in our system, as evidenced by the National Mental Health Commission's report card, is really something that has landed with us and stayed with us, that is not really reliant on very much data whatsoever in terms of the measurements that matter to people in terms of their outcomes, for their families, for themselves, and the impact of these services and supports. And so for us, this report fills a tremendous gap in terms of providing decision-grade data to fill some gaps moving forward. And so just to finish off before I hand over to Paul, I just want to acknowledge that this work that we're doing today will highlight a tremendous amount of advocacy work that's been done over decades, really by the people who are the giants, and many of you are here today, of a movement. And these are the shoulders of these giants that we stand on. But you'll notice, and you may notice a response in yourselves, where the report does highlight significant gaps in terms of our current measurement systems. There are gaps in terms of human rights, in terms of social and emotional wellbeing perspectives, on families, culturally and linguistically marginalised communities. And so, of course, at the end of this webinar, I absolutely invite anybody to connect with us to continue this conversation, because we understand how meaningful and how deeply this work matters to many of you in this room, including allies that are here today. We will continue this crucial work to continue to build this evidence and to engage with the states and territories to continue this important conversation, because critically, we commissioned this work in the context of the intergovernmental agreement that is being negotiated at the moment as part of the Mental Health and Suicide Prevention Agreement. And we intend to use this to advocate into that space. We absolutely welcome further questions. The intent of today's webinar is to have a significant period of time dedicated to questions and answers. And finally, of course, we thank Paul, Lizette and the team, including Zoe and David at UWA, for their incredible close attention through deep listening to language and to intellectual curiosity, which is an absolute necessity working in this space of mental health. So now, Paul, I'm going to hand over to you and let you lead the way. Thank you.
Thanks, Kerry, and thanks, Cathy. And as I get this little machine ready to go, just to mention that this is a report commissioned by Community Mental Health Australia. And today we're launching the report. So you're the happy recipients of a report that has just landed. And I'll just ask someone to put the report into the chat so that you've got a link to that report and you're ready to go. So as mentioned, here we are launching a report on capturing the economic value of psychosocial support, commissioned by Community Mental Health Australia. And I'd like to begin and again acknowledge the Watchunga people in UWA, from the UWA end hosting this seminar, and Ngunnawal people for Canberra. And pay our respects to their elders past and present, and to all Australia's Indigenous peoples. So that's the title of the report, which you can now download from the CSI website. And just to confirm a point by Kerry, investing in psychosocial support is not a cost to be managed, but an opportunity to be seized. And from an economic point of view, it is an investment that has a very strong return. Now, what is psychosocial support? The Psychosocial Support Project Group defines as a non-clinical and recovery-oriented services delivered in the community and tailored to individual needs, which support people experiencing mental illness, mental challenges, to live independently and safely in the community. And it can involve a number of different things: housing support, social support, substance abuse support, community participation, and so on. So it's a range of social supports that are part of an important recovery process. And the aim of the report is to provide an overview of the existing economic evaluation evidence in relation to psychosocial support programs within Australia's community mental health system largely. And our framing question is, what do we know about the mental health, social and economic outcomes of investing in psychosocial support? Well, those economic benefits improve quality of life, and which we can value in dollar terms. There are a lot of studies, which I'll refer to a bit later, which talk about improved life and what kind of impact that can have. It can be actually estimated directly. Then there can be labour market and employment-related benefits, and what we call cost offsets derived from programs, which are reductions in systems costs, including hospital costs, because the program is working. So you're spending money, we call it investing money, to enable you to improve outcomes for people, which has the added benefit, significant added benefit of reducing budget costs elsewhere, therefore creating a significant return, measured for both beneficiaries, carers and families. And as mentioned by Kerry, we don't always get that family and kin benefits into measurement. That's an area where we need to improve. Let me give you a little bit of economics here. For those who've done economics, done a little bit of maths, you've got a vertical axis, horizontal axis. On the horizontal axis, we have outcome differences. And on the vertical axis, we have cost differences. The difference between psychosocial support program and the program. So if a program produces good outcomes and has net costs, that's a good standard outcome. But what we can see with cost offsets in the work that we've done and others have done is we actually get to another quadrant, which is that we get the good outcomes along with actual net savings resulting from the program itself. Let me go back in time to work that we did 7 or 8 years ago. And we did this work where we were looking at one of those classic psychosocial support programs where people were moving from homelessness with significant mental health challenges and into housing with support. What we found in that program was an incredible cost saving using linked WA health and public housing data, cost saving of $119,873 per person per year in March 2026 dollars. And we saw reductions in emergency, decreases in hospital admissions and the like. Now, this doesn't always occur because sometimes people do need to have health needs met. But these were very significant savings, and it came about because those who were experiencing significant mental health challenges, including periods in residential mental health care, found stability and found support, and their lives improved, resulting in these cost offsets. So that's just one example. But let me talk about the Productivity Commission report from a number of years ago now. That's an incredible report, which estimated that mental illness on a conservative basis is costing Australia about 200 to 220 billion per year. That's a huge cost, where they did a number of very good estimates, including quality of life, cost offsets, and improved labour market outcomes. Now, Kerry and Cathy mentioned the important role of lived experience and how that lived experience provides an enormous insight into the benefits that psychosocial support programs provide. So in the report, you'll read about Len, Peter, and Haley, their experiences, physical, mental health, social and cultural outcomes significantly reduced with Len. Loneliness and social isolation reduced, living skills improved, employment and career benefit opportunities, reduced hospital admissions. And in Haley's case, which is her actual name in this case, crediting a psychosocial support program for saving her life. What we did was to then review all the literature around on these kinds of lived experience insights to understand what kind of cost implications came from this, what kind of economic benefits. For example, there was a 2016 study which estimated a 10% reduction in loneliness could reduce mental health related expenditures by around 4.4 billion. Another study which looked at psychosocial support programs attached to suicide and the implications in terms of costs from suicide, non-fatal suicides at work, 9.3 billion. So there are these significant economic evidence out there around this. Let me look now at another side of the report, which is that we were looking at a piece of work that had been done a couple of years ago, very good piece of work, health policy analysis of unmet need for psychosocial supports outside the NDIS. They didn't actually do the economics of those programs, but they did provide an indication of the levels of high unmet need and also listed a number of programs, 63 odd programs, which were then examined in terms of how they ran and what kind of programs they were. So we examined those 63 programs and we come across now a second important finding. So the first is that where we do have evidence, the evidence is incredibly strong around psychosocial support programs. But in looking at the HPA report, only 10 programs of the 63 had associated evaluation studies that included economic evidence. And of the 9 studies covering the 10 programs, only 6 had undertaken a cost offset analysis. So we do need better evidence in terms of a wider set of evidence in looking at psychosocial support programs. One of those 63 programs, of course, did have very good economic evidence where there was very large cost offsets. And we had an increase in quality of life that cost less. In other words, it was in the dominant quadrant. So there are these important findings, strong evidence from a small but robust set of program evaluations, very strong evidence from economy-wide studies around the benefits of psychosocial support programs from an economic point of view. We want to see more evidence. We want to see a very good piece of work, the Productivity Commission work, extended, those lived experience insights examined, and existing strong economic evaluation developed further. So further modeling and the absence of those program evaluations we feel probably has a detrimental effect on the rollout of psychosocial support programs. So we do want to see more modeling in that area. So a recommendation for increased funding in this area and a commitment to share evaluation findings as well. So let's just confirm again our points that psychosocial support programs have mental health outcomes, social outcomes, and economic outcomes. And the dollar value of those economic outcomes and social outcomes and mental health outcomes are very significant. And the investment in psychosocial support programs produce benefits. So we need to develop those economic analyses through these kinds of mechanisms, in impact evaluation with specified counterfactuals, and then moving on to economic evaluation. So in conclusion, when people get the support they need, that is empowering, that addresses their whole of life needs, and that's through psychosocial support programs, we see significant benefits for the individuals, for their families, and society. But there's also a need to develop greater maturity in data collection, research design, and information systems. So thanks very much. And we can now turn over and get some questions for us all from the group. We're, I think, right on time. So plenty of time for questions. I hope we've got in chat the report to be downloaded. So you can have a look at the report. I did notice one comment, yeah, the 2017 citation, there's about 300 footnotes in the report. So you will find the citation there, and Zoe no doubt has probably even put the citation in the chat for you. So we now will open it up for questions. So in the chat area, we have questions coming through, or points being made coming through. You can now look at adding into those questions. You can also put your hand up and ask a question directly. All right, so let me just check. Slides will become available. Yes. The report is available. Yes. And the webinar landing page is available. And you will get the citation for the 2017 study almost as we speak, no doubt. But let me direct a question to Kerry, actually, and to Cathy. Do you have recommendations for the impact investing in philanthropy sector, how we should get involved in psychosocial supports? Now, that's an interesting one. Hand over to you, Kerry and Cathy.
It's a very welcome question. And in the report, there is an example cited of an open dialogue pilot in Goulburn, Shepparton in Victoria. And so I think there are any number of ways we can work effectively within the philanthropic sector. So certainly proof of concept, examples like the open dialogue one that's in the study. We would, CMHA would very much welcome any conversations about how we can move some of the system barriers that sit in the way, move that forward. So we have any number of examples overseas of both World Health Organization guidance, the United Nations recommendations, examples of very, very successful implementations of psychosocial support. In Australia, we have significant barriers, and so we would absolutely love to talk with the philanthropic sector about how we can do it both at a program and service level in terms of demonstrating proof of concept, but also having a serious look at some of those systemic and structural barriers that are actively working at the moment to prevent further investment. Cathy, I don't know if you've got some further suggestions.
I think, Kerry, you've probably hit the nail on the head. The one that's really appealing, I think, that could really provide some insight is the open dialogue methodology, where we actually get to speak all of the people who are involved from the person's perspective in their life and just see where the massive gaps are. It also would create a really strong opportunity for us to work in a complementary way with mental health services to be able to get them to see what happens in community is so critical, important, because we all exist to ensure that people have a better life. That's the aim for all of us, I would imagine. Certainly CMHA, that's where we're coming from. Thanks, Kerry and Paul.
Fantastic. And I'll just go to someone who's raised their hand. Kat, if you could unmute now, you've got that capability, and ask your question.
Oh, great. I'll just check my mic is working. Can you hear me?
Yes.
Great. I was curious to know what kind of questions when it comes to research. I started a PTSD peer support, which is an online peer support lived experience community for people recovering from PTSD. And it runs 365 days a year. I do a meetup every morning, and I'm seeing these profound transformations happen within that. And we run an evidence-based topic on wellbeing each day, and then we have an open share. So I'm at the process now because I'm in a rural Australia. I started it because I got PTSD and I live in a property and I didn't have any mental health contact. And I'm trying to look at how can I do some research to be able to start looking at being able to apply for funding or being able to move it into a not-for-profit or something to build it, because at the moment it's run on donations, it's free. So it's we've got a few supporters, but it's sort of a funding gap now of needing to expand more. But I need to do some research so that I can, or do some questionnaires or quizzes so that I can present information to potential investors.
Well, just from my point of view, one of the things you can do is have a look at the evidence presented in this report, and where you do have information that you've collected from those engaged in your program. It may be qualitative information, but it's in a clear direction and robust, informed for the case that you are in. Then link it to the economic evidence that researchers and others have presented. So I gave you the example of loneliness, where we saw from lived experience the reduction in loneliness. Well, there's a lot of economic evidence around what does that mean for society, and that's one avenue that people can follow when they can't build their own information quickly. And then, of course, the funding for measurement evaluation for small organisations is simply low, as you no doubt know. Yeah. So you start to build a case from the existing evidence base. And have a look at the Productivity Commission. There's no more robust piece of work on the economics of mental illness than you see with the Productivity Commission report. Huge report. Any other comments from Kerry and Cathy on that?
Thank you.
No, nothing to add.
No, thank you, Paul.
And good. And we'll have another question from Margaret, and then we'll go to some of the chat questions as well.
Yeah, I'm just wondering, what age groups are you encompassing into all of this?
The age groups are any age groups that were participants in the psychosocial support programs. So it goes up to any age level, and generally speaking, the programs weren't generally for children, but Kerry and Cathy, you'd be able to talk about the participants of psychosocial support programs.
What about older adults? Because we've just been developing for the last few months the philosophy of care for older adults in mental health. And sadly, we found some really startling information and research, which is sadly lacking. And these are older, because they've been in the mental health system for years, and then they transferred over to the older adults' mental health. And there's really no, it's basically chuck medication at them. And then if they've got dementia as well, or on top of, yeah, sadly lacking. So it's like, and you see, you go into things and you have a look and it says, oh, up to the age of 65 or up to the age of, it's like, they've already buried you. It's like disgusting. And it's the same as your physical health, and everything's divided into little groups. And I feel, well, we feel in what we've been doing over the last few months, that there's a lot lacking, and the philosophy we've developed, hopefully, is going to be adopted, and translated. It's got to go further, because then it's got to be actioned. It's got to be translated into the doing.
Fantastic. Any comments, Kerry, Cathy?
You go, Kerry. Then I'll go.
I was so Margaret, welcome and thank you. You're one of the giants of the movement. In fact, I think you were probably the first person 15 years ago who reframed mental health as intergenerational trauma. So yeah. Really appreciate your work and your commitment.
And talking about, is it Cat? I'd really like to join her group, because finally, after 40 odd years of the wrong diagnosis, somebody decided to really thoroughly look through my notes, and I have got really severe post-traumatic stress disorder. I've always known that. But unfortunately, the mental health system get it so wrong. And I can understand why they get it wrong, because post-traumatic stress disorder was only really recognised a few years ago in service people, you know, war people and veterans and things. But it's much bigger. It's a bigger thing than that. And I'm actually joining the research centre for the children's research thing. I'm just going to be participating in a new venture of theirs that they're looking at about dissociation and things. And I feel that we really lack the real judgment of people who come into these systems and services, and especially when they're young, which is a shame, because they'll end up like us, you know, absolutely traumatized even more from the system itself. And families are blown apart. I mean, I don't even have a family speaking to me now, you know. And you mentioned families. Well, I grew up with a mother with mental illness as well. And of course, I am pretty pissed off about the whole system. And having done that work for years and years, and even before 15 years, I was doing it. I look at it and I go, God almighty, we are spending billions of dollars on the wrong stuff.
Yeah.
We're not really looking into, we're not addressing all the causes of mental health.
Exactly, Margaret. Yeah, I'm sorry, we'll probably have to move on. But,
I know, sorry, but I'm just...
No, I totally understand. And I titled my introduction slide as the context is the signal, not the noise. It is all about context, absolutely.
Good on you, Kerry.
But I thought I might just throw to Cathy to answer your, it's fine, to answer your original question, because I know Cathy's had a lot of thoughts about this and a lot of frustrations, and certainly a lot of the limitations for programs, including the NDIS, are age related. And once you hit 65, of course, you don't have access to the kinds of supports you should. And often, as you're saying, many people have been through the system and been harmed by the system. So very, all of your points were excellent. But I might just throw to Cathy in terms of that original question. Yeah.
And thank you, Margaret. I thank you so much for raising older persons. This is something I'm very, very passionate about. I have a mother who was 92. And my father died in his late 80s with dementia. My mother has recently, just by example, gone into an aged care facility, which is very good. We had every question known to mankind about her health, where she's come from and all the rest of it. Not one question about her mental health, about what was the anxiety she might be experiencing moving from her own home into a facility. So I have done a little bit of, I've started with the residency where she is with, I've done some work in 7 Ways to Wellbeing for community. And we did a frame of that around older persons, which was one of the best we did for the participation that we had. So I've started the conversations where mum is to talk about how will you address and get people comfortable to understand this is the last stage of their life where they've gone. It does have a mental impact. How are you going to get them to adjust to this is their home? And how, as an organisation, will you work with that? It does appear over 65, you disappear over the radar. So I'm gone. I'm past the radar now. But it is a very important question. And I do believe that we need to do more with it, particularly around some prevention, early intervention, where people are transitioning maybe from their home to a retirement village, even retirement village to facility. So thank you for raising it. And that certainly is in the forefront of my mind. Having worked in the mental health space between 2002 and 2016, it was very evident to me when, particularly in the employment space, when we had older people coming in who were almost in some cases forced to seek work. And I'm talking to people who've been very unwell in their late 50s, early 60s. And I thought there's a lot more to life that needs to happen before we worry about a job, so that we can actually get the person to the stage where, of course, they wanted work, but we needed to have much more of a community focus. And my question is, what is local government doing? They look after community. So there's a lot of work that we have to do. But it is really pleasing to hear older persons raised, and thank you very much for doing that.
Good. And just to let you know that Zoe's been answering a number of these questions as we've been going on, such as the clubhouses are there. Yes. Some of the references. So Zoe will continue to look through some of the questions in chat and answer those. We definitely see a need for funding into the psychosocial support area, just as we see in, say, the PBS in health economics, just as we see in the clinical area. And it's very important that funding comes in at before a program starts, so that the data can be collected, and that where we want to have linked administrative data, we can get that consent where a person gives consent. We can set up the right kind of survey evidence and the like. So yes, we would like to see that funding being provided to organisations and to researchers jointly to develop those programs of work. The outcomes that we want to see measured, well, it's a broad range. So, I mentioned things like cost offsets, clearly important, but given the work around quality of life, recovery, loneliness, these are very important outcomes as well. And they're important in themselves, but we can also measure the economics of that too. So there's a lot of data that we need to have, but we need the funding to come in at the beginning, and work around this has always been that the community sector tends not to get that level of funding that it needs to do good work. And it can have very good research partners at various points, but generally speaking, it is in the measurement and evaluation area that we do need more consistent funding so that we can get the better we need. Let me go to Ria. I think I've got the right name there, Ria. So Ria, if you could unmute and you can ask a question.
Yeah, I suppose it was a comment, and I mentioned it in chat there. What's having not read the report just yet, what's the sort of angle on the adolescent, acute crisis and that sort of thing? Because we're finding in this region, I'm on the border of Victoria and New South Wales, and we just had a mental health youth sort of forum recently, looking at exactly what we can do, and we've got 54 beds in the state of Victoria for our young people, at best 16 plus. They may get admitted to 2 of the local adult facilities, which is clearly not very acceptable for young people, and it's a 4-hour, 3.5 sort of hour trip down to Box Hill, which is in Melbourne, our nearest opportunity. I certainly gave a speech at this regarding sort of the overflow. We talk about who's directly involved. Obviously, the local young person, Youth Citizen of the Year, she's gotten this off the ground, Katie Kendall, and I was her teacher. Just her English teacher, and I sort of spoke from the perspective not of the lived experiences directly, but of the fallout in the community for your coaches, your employers, your family, friends, and your teachers who are winging it, because Katie said to me, "You kept me alive some days," and that sits heavy when you're just a teacher, and looking at those other further actions in the community that we can take in terms of sort of training for people and stuff like that. So how is this sort of responding to, I suppose, the youth end of the spectrum? Was there a lot of work done in that? Sorry.
Yeah, sorry, I'll let Kerry answer. I think she's just about to jump in there. Yeah.
Thanks, Paul. And so the short answer is not much. One of the reasons we commissioned the report was in particular to provide some advocacy into the negotiations for the next upcoming National Mental Health and Suicide Prevention report, and on which it sits in terms of analysis, the HPA analysis that the Productivity Commission had recommended, and those programs are age defined, and so there wasn't much in there in terms of evidence relating to children and young people. And I would, go even further and say, having had deep, long experience in the space, that we can't forget infants as well. And so for us, this is a springboard. This is just to establish now a tiny, tiny toehold on the evidence ladder that says that these approaches work for everybody. And we would be very interested moving forward in how we can grow that space. And when you do get a chance to have a look at the report, I would urge you to have a look at the open dialogue implementation in Shepparton, because that is youth focused. And that is all about young people, whole of community, activating self-agency, non-pathologization of distress. Quite an interesting piece to have a look at, and it's been funded by philanthropic funding, so it's quite well developed piece of work. So I'd certainly direct you to that. Paul, I don't know if you've got anything to add.
Yeah, it's very interesting. I just want to pick up on the acute side of this, that it is very important to have that clinical acute service delivery, but in the work that we did that I mentioned in terms of cost offsets, that was alongside the actual psychosocial support. And what was happening there was that as that support was being provided in their own homes now, that led to a reduction in the need for the acute services. So you want to have acute services in play. If you're having to drive to Box Hill, I mean, I can't remember exactly how, was it 3 to 4 hours to Box Hill? I mean, that's an incredible drive, and that suggests that there is a need for those services in regional areas. But the whole point is that the psychosocial support programs, sitting along these clinical programs, can really work wonders. Now, Sharon, I think you've had your hand up for a while. So just turn off your mic, your mute. You're ready to go.
Yeah, thanks for the webinar. We heard lots of information and acknowledge for the psychosocial work that people delivered. I would like to add something and ask a question. I based in WA. I work with an organization called ASSET, work with refugee asylum seekers who experience social trauma. So we deliver mental health. This is like a primary services, and we deliver some community work with refugee asylum seekers. I'm part of the community development team, and through the project that I deliver, we deliver psychosocial activity. And thanks for the webinar, like the highlight, the outcome of everything that we delivered, even in non-clinical support. There is during my work with ASSET, I study mental health, master in mental health, and I struggle to find something that support non-clinical work as a research and project, or some study that focus on the outcome of the psychosocial, mainly psychosocial, from non-clinical background or like support. So is there any plan or like in the future to run some project or research to do some work with mainly with refugee who experience social trauma, as we use all these approach and modules, and we test some of them as, you know, like your expertise in this field. So sometimes we twist the modules to fit culturally appropriate for a client regard to their background or their experience, mainly when with torture and trauma experience. Thank you.
Yeah, I mean, I know of ASSETs, obviously, and the great work that you do. I've had that experience of working with community organizations, with refugees, particularly with asylum seekers, where the funding just is not there. Whilst we talk about the community mental health sector in general not having the infrastructure support and the evaluation monitoring support, it becomes even more severe when you're talking about asylum seekers, in particular refugees. So I know exactly what you're talking about. Now, Kerry and Cathy, do you have any points there?
Thank you for raising your points. Townsville is a refugee settlement city, and I've had involvement, a lot of involvement actually, with refugees and asylum seekers here. And you're right, it's one of the things we talk about a lot at CMHA, apart from our broader mainstream, what about First Nations and cold communities? One of the things that I see that is a glaring issue is we have an outputs base. We don't do much in actual real outcomes. But apart from that, my experience is the language barrier. And we need to do much better with that language barrier in how that we can, like, it's not a one size fits all jumper. And the sooner we can work that out, the better. But how do we work with communities who do business very differently to the way we do, and they are community based? How do we address the language barriers? How do we give them opportunity to have their voice heard? And I think it requires us to be a lot more patient. We need to have a lot more interpreters involved, and we need to genuinely listen to what life is like for someone who has left their home and come to a strange land seeking safety and the benefits of this wonderful country. So thank you for raising that. I think this report will give us much to look at in terms of the questions you raise, and we certainly will be looking at that from a board strategic perspective. Thank you.
Sorry, I do want to take more time from others, but we usually partner with some research through UWA. There is a couple of research we support or like partner with UWA on that. We provide, like, for example, language support or culture appropriate support as well for a client to share their experience. And yeah, so if there is anything in your mind or like in the future, we would like to involve, that will be a good opportunity for us as well. Thanks.
Good, thank you. I think it's Wendy. You've had your hand up for a little while.
Yeah, thank you, and thank you very much for the report. You know, it's great to see. I suppose mine's a bit of a comment and a question. It's the old output versus outcome measurement, and I suppose some of it's great to see that we're putting dollars to outcomes. And just wondering about your thoughts about in delivering that message. You know, and when we've got systems that are very focused on outputs. And I suppose I'm always aware, I'm looking at, you know, I'm loving the idea that this work's going to go further, because I'm very aware of the cost to family and communities when there is no psychosocial. But I suppose my concern is about the consistency about how we're measuring outcomes and what those frameworks look, and the, you know, the obstacles in trying to implement them into that. So yeah, thank you.
Yeah, thanks, Wendy. And just as you mentioned that, in a capability development piece of work here in Canberra, specifically on the measurement and evaluation space, and talked about output and outcome measurement today. It is an area that has gained a lot of interest from community mental health organisations. So there's and a lot of capability development is occurring. So we are living in a somewhat different world. There is greater knowledge of that distinction between outputs and outcomes. When you are delivering your services, you're doing it for a reason, to make a difference to people's lives. And so therefore there is great attention on measuring those outcomes. One of the issues that we face in terms of measurement and evaluation is that, you know, as a rough rule of thumb, you're talking about 10% of a budget. But as your budget gets reduced, you actually have higher fixed costs, so it actually goes higher than 10%. And if your budget is in the millions, you can go less than 10% because those fixed costs are being spread out. But what we find in the community mental health area is those budgets to deliver services are squeezed. Then that has the further effect of squeezing measurement and evaluation. And it doesn't always get built into pricing. So we do need to build that into pricing. And we need a broader scheme, a scheme that supports that measurement and evaluation across the sector, recognising that the budgets are often quite low, so very difficult to deal with. Yeah, so thanks very much for the question. Any comments, Kerry and Cathy?
No, I would just urge you, Wendy, to connect with Mental Health Carers Australia, one of our lived experience partners that we're workshopping this through with Paul in a couple of weeks. So absolutely need to make sure we're capturing exactly those issues flowing right upstream to commissioning and cultural attitudes in commissioning as well.
Mm-hmm. And that brings us to the fact that this is another step on a journey. So the release of the report provides a lot of that evidence, but now we need to workshop it with others. And so we will be in Melbourne, we will be in Adelaide. I think Kerry probably has more plans for us downstream, but good. And off we go. Now, I think we're at our last question. Jeff, I know Jeff was online to take the last question. Where is Jeff? No?
Yeah, I was hiding a bit.
Okay.
Yeah, look, I feel like you're almost getting to answer my question. Like we've been advocating with our state government that if they're going to increase investment in psychosocial, that they should invest in independent capacity to do look at impacts and work with stakeholders around like a continuous improvement process. Mm-hmm. Like often you find services aren't evaluated at all, or they get evaluated after the decision's been made to defund them. But interested in that, like trying to link it up with improved services as you go. And I'm wondering whether you're aware of such a kind of approach in other sectors.
Yeah, well, we obviously have examples in the clinical area in the PBS, where there is a dedicated program of health evaluation, economics evaluation. So we do have those infrastructure spends in the more clinical areas in PBS pharmaceuticals. And we do have some investments in monitoring and evaluation frameworks and the like. So there are examples, but as you get more and more in the community sector, the community mental health sector, so difficulties arise in terms of the funding that's available. So that's part of the effort that's ongoing, not only to build the psychosocial support programs available from community mental health, but also build the infrastructure base. So yes, there are examples, Jeff, and we do need to see that spread out. Interestingly, when we tried to get a good measure of the total value of spend in the psychosocial support area, it's actually impossible to get. You can get the Commonwealth program spend, but you can't get the total spend. And AIHW, we really do need to give them the opportunity to actually measure more directly the actual spend on psychosocial support programs, let alone the measurement of evaluation spend. So there's a lot of work to do going forward. Now we're close to the end. You obviously saw the download sites, so you just download the report now. And this seminar will be available as well, so you can get a recording of this, play the recording back, including any background noise coming from my end in particular, and have a look at that recording. So all is available to you. I'd like to thank Kerry and Cathy. Any final words, Kerry and Cathy, particularly of the work coming up?
Just like to say thank you, Paul, to you and Lizette and the team, and to Kerry and the team at CMHA. This is such an exciting opportunity. There is much to do, but we have the enthusiasm and the drive to ensure that it happens, because it's time now to put our boots in action and just move forward. And we'd be very happy to hear from anybody who has ideas, to connect with Kerry through CMHA, and just to say we are so proud of the work that has been done, and to everybody who has contributed and to everybody who has attended today. The energy has definitely been in this webinar, and thank you so much.
Thanks,
Cathy. And I would just add, just to come back around to the fact that this is an economic report and it's about people, and we've heard that very, very clearly today, and we don't intend to lose sight of that. We know that we need data, we know we need decision grade data, we know this is an economics conversation with Treasury at the end of the day, very often, because it's about system transformation. And so this work absolutely complements and will be led and guided by our partnership work with the Lived Experience Peaks and GAIA moving forward. So thank you.
Yes, and thanks so much. So we do have a few notices about where you can get the recording that Carol will be just putting up now. Thanks everyone for being engaged. It was interesting to see that we had at its height, I think, more than 150 people online. So it's quite rare that you actually have a research seminar with 150 people online, I can assure you, from the university world. So it shows the level of interest in this, and we hope to be seeing a number of you as we fly around the country and talk to various people. So thanks everyone, and we'll leave it at that and say goodbye. Thank you.
Thank you.